Well, one thing that was asked recently, and we've had an email discussion about this, is how to confirm tube placement with ultrasound and some of the merits of different strategies. Do you want to talk about that some, Rich?
Yeah, absolutely. So why would we even think about using this? Well, obviously, sometimes your patients may decompensate. Maybe you're doing an intubation and x-ray is not available in either case, right? So sometimes you have to make some rapid decisions, and maybe you can't do an x-ray. It's loud in our resuscitation bay, so auscultation isn't always the best. I think ultrasound can be a nice adjunct to your evaluation to confirm tube placement. So the first thing that you want to know is the tube in the trachea. And you can do this real time as a resident or an attending is intubating. You can have, this is ideal as a supervising role, right, to look to see where the tube is going. The tube is easily visualized in the esophagus. You can see it very easily. The esophagus is usually in the left paratracheal space. You just place a linear probe kind of next to the left lobe of the thyroid, and you can see that tube in the esophagus very easily. It's quite easy. On the other hand, when it's in the trachea, you almost see nothing. You might get a little flash as the balloon goes by, but that's contingent upon the trachea or the balloon being in touch with the tracheal wall, right? Because there's air that's around. So a lot of times you don't see anything. So for me personally, if I don't see the tube in the esophagus and there's reasonable depth to the tube, it must be in the trachea. So the next question is it mainstem? So you can do your sliding lung bilateral, and if you have sliding lung bilateral, then you must be ventilating both bronchus, right? So theoretically, it would be above the carina. In my personal experience with this, I think sometimes, particularly early on, you may still see sliding lung even though there may be a mainstem there. So I'm not as heavily reliant upon that. I'm talking about maybe doing a research study with scanning the lateral size or posterior size because air is going to try to rise. So my theory is that maybe the sliding lung will leave earlier lateral posterior, right? So
which makes a lot of sense that the farther lateral you go. A common mistake in the trauma patients, I see a lot of you guys listening for bilateral lung signs, and you're going so anterior that you're kind of like right near where the nipples are, like the midclavicular area, which is not an ideal place to listen to bilateral lung sounds. The farther you get laterally, the more likely you're going to pick up an absence of lung sounds on someone that actually does have a pneumo or something like that. So be cautious about just listening in the front. I've been fooled more than once about, I hear a little bit of lung sounds, not quite as crisp on one side versus the other. And if you're too far anterior, you certainly have that risk. We haven't proven that with ultrasound yet, but I think it's an interesting idea that certainly has merit to